Hi, everyone. Welcome to the end of October Biocurator Working Group call. We'll give it a few minutes as people join. Kazan, can you also make Mary host so that she has sharing permissions? Okay, it looks like our list of participants is relatively solidified, so I think we can get started. Welcome to the Biocurator Working Group call for the end of October. Today, we're going to have Marian Gilmore give overview and updates of the Actionability Work Group. We did originally also have a VCI topic. Hopefully soon the Nomad V4 data will be available in the VCI. However, we've had a change of schedule, so we will talk about that sometime in the future, but just keep that on your radar. We will definitely be sending a communication out when those data are available in the VCI. As far as announcements, I know oftentimes that Google Calendar invites don't come off of Outlook calendars or other calendars. So just keep in mind, we'll send out reminders too. Both November meetings are canceled, one for Meeting Free Week in genetics and the other for the American holiday of Thanksgiving. So we will not meet in November. The next meeting will actually be Wednesday, December 11th at 4 p.m. Eastern time, which is our yearly celebration of ClinGen volunteers, where our steering committee chair, Courtney Thaxton, will give an overview of all the curation progress that we've had in the last year. The other announcement that I wanted to mention is the sign up and RSVP for the ClinGen luncheon at the American Society of Human Genetics meeting is now open. I have stuck that link in the chat. This will take place on Thursday, November 7th from 11:45 to 1:15 p.m. And we're doing hopefully a very exciting session where we'll be brainstorming ideas, innovative ideas for our next round of ClinGen grant submission. So if you're attending ASHG, we'd love to have you, but please do RSVP because we need headcounts for lunches. Great. And with that, I will turn it over to Mary to give your presentation. Thanks for coming.
Yeah, thanks for having me. Um, all right, I'm going to share my screen. I'm hoping everyone can see that.
Nothing yet.
Oh, nothing yet. Okay, hold on. How about now?
Yep, that looks good.
Great. Okay. Wonderful. So again, thanks for having me. I think our working group last connected with all of you in 2020, so it'll be nice to give some updates and an overview of our process because I'm sure there have been some new people in this group since then. So I am part of the Actionability Working Group. I'm a genetic counselor and I've been on ClinGen for about 6 years. And yeah, we're excited to share some updates with you. So for the agenda, we're going to go over our product workflow for our actionability products, talk about actionability assertions, which we just began working on in 2020 when we last met with all of you, and then some new types of reports we've begun working on, chromosome abnormality reports, so expanding our work beyond monogenic conditions, and then give you some example reports that highlight some challenges that we've experienced in evaluating clinical actionability. So our working group, we really want to identify genes that when they're significantly altered confer a high risk of serious disease that could actually be prevented or mitigated if the risk were known to the individual. So we have our gene and associated condition. They're called gene condition pairs that we start with. And I'll go into all of this in more detail, but this is a nice overview of our process. We then apply our actionability framework, which is our standardized protocol, and our semi-quantitative metrics and rubrics to create our products. So we have reports, we have actionability scores, and then more recently, actionability assertions. As you all are probably familiar with, we then publicly release these to be available with the hope that people that are making decisions for the return of secondary findings based on actionability can use them. Now, the clinical context for our reports is secondary findings, and that's important to keep in mind. We do know that there may not be resources like this for other contexts, like population-wide screening or diagnostics, but we just want to highlight that like the focus of these reports is really framing it around what would we do with this information if it was a secondary finding. We have two working groups. We have a pediatric working group. And so in that framework, we think about, a child with a secondary finding found via genome scale sequencing. They would not be previously diagnosed with the condition, but they could have signs or symptoms related to the condition. And we really want to emphasize that the intervention that we would evaluate needs to have clinical utility during childhood. That would be important, and that's part of what our scores look at as they're generating our scores. We also have an adult working group. So again, this is an adult with the same type of finding. Again, not previously diagnosed, but they could have signs or symptoms of the condition. And again, for this group, they really focus on what interventions during adulthood are expected to have clinical utility. And when we think about clinical actionability with our work, we really think about the ability to apply specific clinical interventions to prevent or moderate specific health outcomes due to that previously unsuspected risk of a genetic condition. And so our reports really focus on well-established clinically prescribed interventions. So patient management section of our report would include things like risk-reducing surgeries. The surveillance sections of our report emphasize things like colonoscopy, periodic evaluations that would be needed, and then circumstances to avoid, so high contact sports for certain health conditions. And we really like when the guidelines are specific to the genetic condition under consideration. And so we try to make sure that we have specific resources for that specific genetic condition that we are looking at. And so, like I said, with our framework, we have our gene condition pairs, and we start there. And then we actually have an early rule out process that's part of our formal framework. And so this early rule out process is completed by our wonderful community curators. And they take kind of an early look at these conditions. And again, I'll go into that in a little bit more detail. And then if the gene condition pair passes the early rule out, then we begin evidence curation. And that's completed by our knowledge synthesis team, our KST team. And so we have 4 curators that generate those reports. We then have our working groups, both pediatric and adult, that do our scoring. So these are experts in the field, and the curators lead discussions with the scores to help establish both individual scores for the individual experts and then a consensus score, as well as individual and consensus assertions. And again, I'll go into more detail, but this is just a nice overview. So the first thing that we need to do is we need to select gene condition pairs. And so these pairs can include a single gene, so like APC and familial adenomatous polyposis, or we can kind of bundle genes together that we know are associated with the same condition. So EpCAM, MLH1, MSH2, MSH6, and PMS2 with Lynch syndrome. And the working groups, we started with the list of genes recommended by ACMG for return to secondary findings back with that first iteration of the secondary findings list. We also look at updated lists to see if there's any new conditions that we would be evaluating. We also do take nominations. So additional gene condition pairs have been assessed by the working group through nomination by both working group members and then also non-working group stakeholders. And one thing I wanted to mention briefly with this group is that we do also check to see if there's a gene disease validity classification on the ClinGen website. There isn't necessarily always one for some of the conditions we've looked at, but whenever there is, we move forward with genes that have a strong or definitive classification. So that early rule out step, again, the step that's done by our community curators, is done to quickly look out for and rule out from further consideration any gene condition pair that does not meet three overarching criteria. One of them is actionability. So would this actually be actionable in an undiagnosed individual in either the pediatric or the adult setting? And then the penetrance. Is there a pathogenic variant with at least moderate penetrance? So we would call that greater than or equal to 40%. At this early rule out stage, penetrance is allowed to be unknown, and then we would flush that out further in the formal report generation process. And then burden of disease. Is this an important health problem? Um, Now, I will say, I think that especially for burden of disease, that can be somewhat subjective, which I think I'll highlight in some of our example reports. But this is kind of the first pass that we take to try to establish if a topic would move forward. So then our KST team generates the summary report. So the purpose of the report is to document and summarize the available evidence related to the key features of actionability that I mentioned. So we use a detailed protocol to systematically identify relevant literature to make the process standardized and reproducible across the curators on the team. And the protocol identifies evidence somewhat limited in scope just to make the process feasible. We can't look at all of the available literature. That would take a really long time to get these reports finished. But we tend to look at clinical practice guidelines, systematic reviews, meta-analyses, OMIM gene reviews, Orphanet, clinical utility gene cards. We, look at NCCN if it's a hereditary cancer condition, things like that. We typically don't include narrative reviews or primary literature. And then all of the evidence that's in the report, we actually tier it based on quality to prioritize what actually goes into the final report, but then also to help guide scoring, as you'll see later on with our semi-quantitative metric. So tier one evidence is from a systematic review, a meta-analysis, or a practice guideline based on a systematic review. Tier two is what we more commonly see, which would be information that's from a practice guideline or expert consensus with some level of evidence review. Tier three would be from a non-systematic evidence review, so like a gene reviews or an OMIM entry that has cited primary literature throughout. Tier four is typically evidence from a non-systematic review of evidence, but they actually have no citations to primary sources. So that's how that would differ from the tier three. And then tier five is the type of evidence that is not systematically identified through our process, and I'll give some examples of that shortly. So what we do next is we abstract the data from the highest tiered sources that we have found in our search for the 5 domains that are associated with clinical actionability. So the nature of the genetic condition, we have sections in our written reports for prevalence, clinical features, and natural history. And then for actionability, like I mentioned before, we really focus on patient management, surveillance, and then circumstances to avoid. And then we have a section for likelihood. So the prevalence of the associated genetic variants, penetrance and relative risk sections, as much as information as we have on those. And then also a variable expressivity section. And then we also have a nature of intervention section. So what's the risk and the burden of completing these interventions that are mentioned in the actionability section on the patient? And then the chance to escape clinical detection essentially is evaluating, what would how likely are we to identify someone prior to harm happening in the clinical setting, them having a health event due to one of these conditions? So, to ensure that our reports are complete and relevant and have everything that we need, sometimes we have additional sources that we identify to supplement some of these conditions. Some of these conditions are very rare, and there isn't going to be a standard clinical practice guideline for them. So sometimes we do include primary literature references cited in MedGen and websites from major health organizations like the CDC, American Cancer Society, and other trusted websites. Any information that's kind of supplementary, like if we see a gap or a hole in the report that we as the curators want to try to fill with Tier 5 evidence, with this kind of non-systematic evidence, we would assign a Tier 5. And again, the purpose of trying to fill in those gaps is to help make sure that the scorers have the information that they need to score the topic. And the reason it's given a Tier 5 is so that the scorers know um, uh, that it wasn't systematically identified, and to take that into consideration as they conduct their scoring and generate their assertions. So then the working groups review the report. So we draft a full report. It's posted for working group review and comment. And then we like to have them review for accuracy. These are content experts in the field, so we want to make sure that there's nothing that was missed or anything that we've extracted that maybe the language is not as clear as we would like it to be, and sometimes we'll make adjustments away from the reference for clarity. And then this is again a time when additional references can be and have been recommended to incorporate into the report. And then we talk about specific outcome intervention pairs that would be scored. So we don't actually score the entire topic altogether. We score specific outcome intervention pairs. So for example, colorectal cancer, which it would be the outcome to avoid, and then colonoscopy, which would be the intervention related to avoiding colorectal cancer in the Lynch syndrome report. So next I'm going to show you our metric. This is a little bit busy, but I'll walk you through it. So we look up at the upper left, we look at severity of the outcome. So a severity score of 3 would be sudden death. That's some of the cardiac conditions that we evaluate would be given a score of 3. A score of 2 would be death or major morbidity. Excuse me. 1 would be modest morbidity. Excuse me. And then a 0 would be minimal or no morbidity. And these are tricky. I would say a lot of times our scores will say like, I want to give this a 1.5 or I want to give this a zero point 0.5. I think that sometimes they struggle with these specific categories. But that's just what we capture as part of the discussion as we're trying to assess actionability for these conditions. And then we have likelihood. So, what's the chance that this outcome will happen? And that's really focused on the penetrance section. So, as you can see here, different scores related to the penetrance that we see. How effective is the intervention to prevent or moderate the health outcome? Is it highly effective? Is it controversial, or is it ineffective? And then, as you can see on the right, we have different tiers of evidence as well for those two scores. And then for nature of intervention, we really try to assess kind of what's the risk, what's the burden, and what's the intensity of the intervention. Like, what's the schedule of the intervention? Do people have to go under anesthesia? Is it a dietary modification? Is it removal of an organ at risk? So a score of 3 would be low risk, medically acceptable, and low intensity. 2, moderate risk. 1, greater risk, less acceptable, and 0, high risk, poorly acceptable, or intensive. So when we look at this metric, I just want to mention, because this will come up later, the total scores can be anywhere from 0 to 12. So that's just something to keep in mind. With a score of 12 being something higher that we would then correlate to our assertion rubric as well. Now, for scoring, our experts really, we remind them to really assume the maximally deleterious variant when they're scoring. I know there can be variants with different levels of penetrance or risk, but we really are trying to focus on when we can, since we're evaluating a gene in a condition, we're trying to assume the maximally deleterious variant. And when we're scoring effectiveness, we want to assume ideal adherence, and also ideal and equitable access to care, which we know is not necessarily reality, but that's what we're trying to assume when we're guiding the scores in these discussions. And the data on the effectiveness of an intervention, it can be extrapolated from a similar condition when there's no data, but it would be downgraded. So we would essentially take that evidence level from um, like it would almost be like a tier two to a tier three. It's not quite like that, but that's how we kind of talk about it with the rubric. So an example of downgrading the evidence due to extrapolation would be like if we're scoring BARD 1 related to breast cancer. There's not really a lot of evidence in a BARD 1 population of the effectiveness of mammography, right? But what we could do is we could extrapolate from the BRCA 1 and 2 report, which does have good evidence in that specific population for surveillance. And then we would downgrade the score because it's not from the population specifically with this gene change. And then the scores, given that they are content experts in the field, they can override the available evidence based on their expert opinion. And that sometimes comes up in our discussions as well. So our assertions rubric, which we published earlier this year, takes into account, like I said, that total score, which I highlighted earlier. So we have our total score. A definitively actionable condition would typically have a total score of 10 to 12. We want the penetrance evidence from an unselected population. And the effectiveness evidence should be from that exact population, ideally, so not extrapolated from a similar condition. And we want evidence that the intervention actually directly impacts health outcomes. So we ideally don't want these like indirect chains of evidence or intermediate outcomes or laboratory outcomes. We really want to see that, you know, mammography can really dramatically impact morbidity and mortality related to breast cancer, for example. And then we have strong actionability. Typically, those total scores range between 10 and 12 as well, and they need to have an intervention effectiveness score above 0. Moderate actionability, same thing, except their total score is typically 8 to 9, and then limited actionability has a total score of less than 8, and they typically have an effectiveness score of 0. Um, and I will say the total sum of those 4 domain scores from the highest scoring outcome related to that previous rubric, that's what is used to generate a preliminary assertion. So in our data interface, as we're going through the scoring discussion, we will click a preliminary or like an automatically generated assertion based on the final score of the highest score for the pairs of that topic. And then it'll give us a preliminary assertion, which would be one of these 4. But keep in mind that the assertion level can be changed. That's the information I have highlighted on the right. It can be changed based on limited or poor quality evidence for any domain score, so likelihood, effectiveness. The interventions widely used in clinical practice may not have been systematically evaluated, but our experts still feel that they are effective interventions. Um, and then sometimes we have situations where high quality evidence or larger studies just would be unethical, you know, for really rare diseases or pediatric diseases, like especially ones that are on newborn screening or something like that. We just aren't ever going to have the type of evidence that we wish we would have to score it as completely as we would like. So we take that into account with our assertions. So our scoring and assertions process, again, on the upper left, we have a preliminary score, and we use that semi-quantitative metric to generate those scores discussion. So we, as the curators, like I said previously, facilitate discussion with the experts to land on final scores for each individual. And then we have a consensus score at the end. The consensus score does need to be the majority, but the individual final scores don't have to all agree with the consensus score. And sometimes our experts will say, like, I understand that it's moderate or it's like a score of 8CA, but I really feel like it should have a higher score, but I'm still comfortable with the consensus score. And then, like I said, the newer work we've been doing over the last couple years is our assertions. And so we start with a preliminary assertion, that kind of computer generated assertion based on the score. We have discussion again with our experts, and then we have a final assertion for each expert, and then a consensus assertion. And again, same as the scores, the consensus assertion just needs to be the majority. So I'm going to give you an example of the BRCA 1 and 2 report because it's one of our topics that has a definitive actionability assertion. So as you can see on the upper left, the genes included in this report are BRCA1 and BRCA2, and the condition is hereditary breast and ovarian cancer. And I'm specifically looking at the outcome intervention pair of breast cancer with surveillance that we scored. Oh, and this should not say pediatric. Sorry, it's definitely the adult working group. Um, Sorry about that. So severity score of 2, likelihood of 3A. So the thing to really emphasize with this report is that we had a lot of really good evidence. So a lot of tier 1 evidence, which this is a common condition. We've known about it for a long time. There's a lot of really good long-term evidence that shows that surveillance can be effective in this population. And so it received a score of a 10AA, which is definitive actionability. And so the actionability rationale, once we generate an assertion, we also draft some language to go along with that assertion. And so our rationale language is here, and it says all experts agreed on an assertion of definitive based on strong evidence of actionability and meeting the following criteria: penetrance, evidence from an unselected population, effectiveness evidence from the exact population, and based on a direct impact of the intervention in the outcome. So this is what we really like to have is we like to have this amount of evidence to be able to evaluate a condition. I will say this is probably one of our few definitive topics in terms of the amount of high quality evidence that we have available. And so, yeah, and here we have, like I said, this substantial evidence. So I wanted to highlight the completed assertions that we've done to date. So um, our working group has been completing reports and releasing them as well as scores for many, many years. And it wasn't until just a couple years ago that we began working on assertions. And so what we did was we actually went back and completed assertions for previous topics with all of our experts. And so as you can see here on the left, we have our adult actionability assertions. So we have done assertions on 170 gene condition topics to date. Most of them are moderate or strong. A small number of them are definitive, BRCA 1 and 2 being one of those. And then we've also done assertions on our pediatric topics, 188 of those. And again, the majority of these assertions are moderate or strong, with a few definitive and a few limited. And next, I want to give you an update on something that we've just recently been doing, which is, again, expanding beyond monogenic conditions to work on chromosome abnormality reports. So this required significant effort from our team to be able to enter these into our curation interface. The first chromosome abnormality condition that we completed was Klinefelter syndrome. It's been scored by the pediatric and the adult working group, and it will be released soon. It's in the data interface, but we just can't release it yet. We need to do some final programming changes to be able to do that. And then we have some upcoming chromosome abnormality reports that are on our priority list, including Turner syndrome and trisomy X. So next, I want to highlight a few conditions that really help better contextualize some of the challenges that we have in evaluating clinical actionability. And I've listed the three here. So the first one is G6PD deficiency. Um, and then another one is our prelingual non-syndromic hearing loss and deafness report, which included a lot of genes. And then Klinefelter syndrome. So here is our G6PD report. As you can see, our outcome is morbidity and mortality with the hemolysis and then avoidance. So it's an avoidance intervention. So avoiding substances that can induce that. What was a little surprising to us was that there really was not good evidence in the literature that we could identify. And so as you can see, that's reflected in the likelihood and the effectiveness scores with the D of poor evidence or missing evidence. And so this was something that we talked a lot about in our group. I was leading this topic and was realizing as I began the evidence creation that there just wasn't much that we were able to pull in based on our protocol. And so one of the challenges we highlighted from this is that, this does have the highest prevalence in populations that are traditionally underrepresented in research. And so what we chose to do, and we do this sometimes, is we actually added specific information in that actionability rationale language, which I'll put on our next slide, to discuss this challenge and kind of this lack of evidence in more detail to make that really clear. So the preliminary assertion based on our rubric was limited actionability, but this was a circumstance where our experts upgraded this to moderate actionability. And then the language says, all experts agreed with upgrading the assertion from the generated assertion due to longstanding management practices for those identified with G6PD deficiency and that follow-up studies after genotyping can assess severity. There's a lack of evidence on the likelihood of severe complications. G6PD deficiency has the highest prevalence in populations traditionally underrepresented in research. Additional research into penetrance could be helpful to the field. And we have another topic as an example that I wanted to mention as well. We did this topic a few years ago. I think Marina, I might have reached out to you about this topic because we were trying to
Yes. Mhm.
wrangle the list of genes, and it was a challenge. It took a long time. So this is our prelingual non-syndromic hearing loss and deafness report. And so again, our outcome is communication deficit, with the intervention being something that we kind of have gravitated to with language, which is like a referral to multidisciplinary care to then facilitate downstream other care or resources. This was evaluated in the pediatric setting, and we gave it a score of modest morbidity of a 1. And so it was given overall a score, or it was given, yeah, a score, and then an assertion of strong actionability. But something that we really were challenged by, and I guess I really leaned on my experience as a genetic counselor, having worked in the clinic for many years, is that, this is not necessarily how individuals that belong to this community would, quote unquote, I don't think they would even score this condition, but that's not how they see themselves and that's not how they see other people. So the deaf community, um, I think would not be necessarily in agreement with this. And so unfortunately, there's a lot of subjectivity that isn't captured in our metric. So especially for severity of the health outcome and the nature of the intervention, that was just really a struggle for us. So one thing I want to highlight on the next slide is some language that we really strongly wanted to put into the report that talks about members of the deaf community and the language that they use to speak about themselves and how that contrasted with the language that we were seeing in the guidelines that we were pulling. And so I wanted to show that to all of you and read it to you. I'm sorry, this is a little bit small. Um, but it says members of the deaf community in the United States are deaf and use American Sign Language. As in other cultures, members are characterized by unique social and societal attributes. Members of the deaf community do not consider themselves to be hearing impaired, nor do they feel they have a hearing loss. Rather, they consider themselves deaf. Their deafness is not considered to be a pathology or disease to be treated or cured. Hard of hearing is more functional than audiologic. This term is used by the deaf to signify that a person has some usable hearing, anything from mild to severe hearing loss. And we pulled this language from, fortunately, there was one guideline that was very thorough and had this language in it already. We did not draft this. That would not have been within our skill set, but we were able to include this language. And then we also emphasized at the very bottom, hearing impairment and hearing loss is terminology from a medical perspective that is often utilized in guidelines. Therefore, this report will use the terms as used in the guidelines. Another thing we did, which was something we have reached out to experts related to like cardiology, right? Like if we're evaluating a rare cardiology condition like long QT or some of the cardiomyopathies, we'll sometimes reach out to content experts as we're drafting the report. But I and we really felt like we wanted to reach out to not a medical expert or like a specialty expert, but an expert like someone that belongs to this community. And so what what we did was I work at Kaiser and through I don't even remember how we found this person, but through some of the resources that we had, we were able to identify someone who is in like a teaching and advocacy capacity, not at Kaiser, who also belongs to the deaf community. And so they were able to review the content of our report. And then they were also able to, I know you can only see it right here, but this reference number 46, it's it's a reference that they recommended we include that was not identified in our search. And it also wasn't used anywhere else in the report because it wasn't like a recommendation to, it wasn't a medical recommendation, right, to do something or to not do something. But it was really a resource for professionals related to community involvement with early education and a guide for hearing detection and intervention. And so we really felt like this person who belonged to this community added a lot of value to this report, and it's given us a chance to really try to make sure that these reports are reflective of and at least take into account the lived experience of the individuals in the population that we are looking at. Okay, the last condition I wanted to give an example of is Klinefelter syndrome. So this again is our first chromosome abnormality report. This is the adult outcome and intervention pairs that we're looking at here. We also scored it in peds. And so we had a preliminary assertion of moderate actionability, but a consensus assertion of strong actionability. So we had two outcomes. One was infertility, and the other one was morbidity from the hypogonadism. And one of the challenges that we really talked a lot about on the scoring call, which just happened a few weeks ago, was trying to evaluate the success of interventions based on the data available in this population. We know that infertility is an outcome to avoid, but it's also a feature of this condition. And sometimes these individuals aren't necessarily diagnosed until they're already experiencing infertility. But then how would we compare quote unquote success rates of some of this between Klinefelter and the general population? We didn't have a lot of that evidence that was generated in our literature search through our standardized protocol. And so that was just something we talked a lot about. And then also, we really noticed as we were having those discussions at the final scoring and assertions call that we didn't have as good of expertise as we may have wanted within the group in terms of people who manage the care of adults in this population related to fertility specifically. And so that was just something that we noticed as a challenge. Yeah, and I already said this was the adult working group. So I think that's all I have for today. I wanted to leave plenty of time for questions. And let me highlight our group, which is very large, as you all know, being part of ClinGen, lots of large groups. And I especially want to highlight our community curators. They do a lot of great work for us, again, at that first step to try to decide what's going to move forward in our process. Yeah, so thanks for having me join, and I'm definitely happy to go back to any specific slides based on any questions that anybody has.
Great. Thanks so much, Mary. That was fascinating and always
Yeah.
good to hear an update about this. If anyone wants to stick any questions in the chat or raise your hand and unmute, we're happy to take those questions. I'll start with a question. I
Yeah.
know that a lot of your actionability interventions have been either in relation to secondary findings, so those individuals that are already receiving clinical care as per the ACMG secondary findings guidelines right now, or affected individuals. Can you speak a little bit to population screening and if your group has any
Mm.
connections to evaluating population screening and what ClinGen's efforts have been on that a little bit?
Oh, that's a great question. I mean, it's so we try to talk about the fact that these are not specifically drafted to be population screening reports, but that doesn't keep people from necessarily using them that way. So there was a recent needs assessment effort that we were part of where we were kind of hearing that sometimes these reports are maybe, there isn't a population screening reference, and so I'm using it towards that, or I'm thinking about it in that way, or so I think what sometimes is happening is that there is a lack, like you're saying, of resources available for other contexts, and so we definitely are, actively thinking about what other contexts, like where's the field going, and how can we maybe adapt what we have to make sure that we are providing resources as best we can related to the work we're already doing, but expanding it into those other areas for sure.
Great, thanks.
Yeah.
And does anyone else have any other questions? You can chat it or raise your hand and unmute.
Oh, I just saw the comment about like the achondroplasia community too. Yes, and I can't remember if we may have done. I'll have to look. I can't keep track of all the hundreds of conditions we've done, but I'll have to take a look at that because if we haven't done it or if we're going to be updating that report, that's a really great example of a condition where we can engage with that community. So thank you for that comment.
Not only that, there is a blind people also, they want to have blind children only. And
Hmm.
that is I think 30 years we know that they selectively even made people aborted specimen who has a normal eyesight. So
Hmm.
that is a dilemma. So we as a genetic community will think that that is normal. For them, that is abnormal.
Hmm. Right.
So there are
Absolutely.
three cases very elaborately discussed about achondroplasia, blindness, and the other thing in detail you have discussed. As a genetic counselor, I'm sure you will be seeing this often.
Hmm. Yeah, and I think that really highlights why I think it probably is like the genetic when I have my genetic counselor hat on and not my curator hat on, why I felt so strongly
Mm,
about that report with the non-syndromic hearing loss was because we had an opportunity to engage with experts that we wouldn't necessarily engage with based on our current format for our reports, right? But I do think it's really important that we be inclusive and take into account the perspectives of the population that we're literally drafting these reports for. And I think that can hopefully, I think that's a bias we have, in medicine is that I think we think there's these interventions we can do to help and we can, reduce the severity of this outcome and that outcome. But people with lived experience with these different gene changes may or may not feel that way. And who's to say which one is better? I think we definitely don't want to be assuming that our medical perspective is more accurate than someone's lived experience.
yeah, it's a great point. And it's something that we've struggled with. I've been involved in a lot of like the disease naming and lumping and
Hmm.
splitting discussions, like
Hmm.
setting policies for that. It's come up over and over again. Should we have some patient advocacy representatives on our groups, like within leadership, at least helping us to make decisions or pointing out, like, this is a case where you really need to consult the disease community because we are making these rules like to be disseminated to the entire community. Have you
Hmm.
guys ever considered having potentially like either a patient advocate or some sort of member of the community more tied to patients, like within your leadership or decision making or any of that?
I know we've at least talked about it. I think one thing we struggle with is like how would we be inclusive if we weren't just ad hoc, like as a report
Yeah,
is on our timeline, for deafness, we would want to engage with a deafness expert, but then, if that person was then involved with other reports, they wouldn't have that same experience. And so
right.
I think I love the idea of it being like a broader ClinGen resource that we could all use, I think that would make it more scalable and more feasible. Rather than at this point, we're just kind of needing to do ad hoc, like, networking, as we come up with
Mm.
those topics.
Yeah, it's a great point. I think the closest that I can think of at this point within ClinGen, but we're starting to have more discussions, is they have a very nice um, Genome Connect board. So like
Hmm.
ClinGen's patient registry, where they have like a steering committee of a little bit of interested, like either patient representatives or advocates that they've assembled for Genome Connect. But I think this is maybe something we really need to think about for a bunch of
Hmm.
our curation activities.
Yeah, that's a great point.
Mary, you have connected about a client filter, and there are
Oops.
often when the baby is born itself, they look it and they sometimes can recognize. And often after they marry and then they don't have children only, they will know that they have client filter, will get a lot of specimens. So much variation is there.
Hmm.
Second one, more concerned testicular extraction and other sperm extraction, they are prone to cancer. That is not you discussed. Gynecomastia, breast cancer,
Yes.
and other type of cancer that can be prevented. That should be emphasized also.
Hmm. And that is in the content of the report that just ended up not floating to the top in terms of the highest priority scoring pair, I guess is the best way to put it by our experts. But it is in the report, if I recall correctly. Yes.
So you're more concerned only about infertility then?
I think what we do is we allow our experts to, we propose certain outcome intervention pairs. We list everything that's recommended for the care of an individual in the context of a secondary finding in our reports. But we tend to focus on the the pairs that are really guided by our experts. So if our experts feel that something would be more highly actionable or has higher penetrance, so it affects most of the population with that condition versus a small number, they may choose to score different outcome intervention pairs versus others. Yeah, and so I can't specifically speak to why they may not have chosen that as an outcome intervention pair. Um, but yeah, that risk would be included in the clinical features of our report and the natural history. And if there's a recommendation for any breast cancer screening that we identified in the literature that we gathered, that would be in the content of the report. Absolutely.
Great. Any other questions? Okay, if not, I will let you all go. And I want to thank Mary again for a great presentation. And just to remind you all, we will not see you in November unless you're at the ClinGen luncheon. Then I'll be happy to see you and chat with you. If not, we will see you at the celebration of curator accomplishments in December. Thanks, everyone.
Thank you.
Bye.